Okay, and I just want to say thank you very much for the opportunity to present this. This is as you can imagine, this is a familial honor as well as an honor of our shared heritage, as well as the amazing contributions that many of the speakers have made to the field of congenital heart surgery and congenital cardiology. So it's truly an honor to be here with my father and with old friends and hopefully new friends in the future. So with all that, I'd like to talk about a topic that will highlight some of the major contributions of some of the speakers who are here and many of the members of the diaspora as well, and something that I've had the pleasure of taking on as dual listed faculty at the University of Pennsylvania, as well as the Children's Hospital, where I operate on both adults and children. And that is mainly the issue of coronary artery disease in the adult congenital population. Just as a matter of housekeeping, I have no relevant financial disclosures and will not be mentioning anything that is off-label in this talk. So what I'd like to do for the next 15 to 20 minutes is focus on providing a brief overview of congenital heart disease and rather coronary artery disease in adults. That will probably be a review for many of us, but I will also like to highlight some of the theoretical mechanisms underpinning the development of coronary disease in the adult population. Talk about the burden of coronary disease, which is something that is certainly still developing as our patients age. And I'll talk briefly about the surgical strategies and the outcomes associated therewith, mostly because this is still very much a nascent field, and there's not a whole lot out there at the moment. So it goes without saying that if we're talking about coronary artery disease in the adult congenital population, this must be considered at least partially a success story. And as we're all aware, 90% of patients who are born with congenital heart disease are expected to survive to adulthood, which is an amazing feat and underscores the immense work that's been done over the last 60 or 70 years. And what that means is that there are more adults living with congenital heart disease than there are children. In the United States alone, there was 1.5 million adults with congenital heart disease, and this prevalence is likely to double by 2050. So in the United States and in the Western world, you can imagine this number will continue to grow, and these patients will continue to age. And what do they have to look forward to? So unfortunately, this is sort of a necessary slide. It's the CDC data on the most common causes of death in the United States. I'm sure that throughout the Western world, heart disease remains probably the #1 killer in most countries. There's no specification as to the type of heart disease in this, just sort of broad overview from the CDC, be it acute myocardial infarction, heart failure, et cetera. But what this comes out to is about 15.5 million people in the United States have coronary disease. There's a 3% prevalence of acute myocardial infarction in the United States. So what that comes down to, just to put numbers on it, is that every 42 seconds in the United States, someone has a myocardial infarction. So, in keeping this in mind, what do we see any difference in the causes of death or the burden of disease of coronary artery disease in the adult population, in the adult congenital population? And there are some similarities. So this was a very well done paper that looked at the various causes of death in the adult congenital heart disease population. And what you'll see is the usual suspects are up there. And if you look at the composite endpoint of cardiac disease, it would be far and away the most common cause of death. So you'd have heart failure, sudden cardiac death, cardiac surgery, and acute myocardial infarction. And there are expected differences among the diagnoses. Really, the focus of this figure is on the far left and on the far right, when you see all comers in the far right and their various incidences. And there are expected differences among the diagnoses. Certain more complex congenital heart diseases will have different instances of the various causes of death. But overall, there's about a 3% incidence of acute myocardial infarction in this population as well, which is kind of interesting considering that was the exact incidence of myocardial infarction of all comers in the United States. And two other additional pieces of information, one that prior to 1990 and presumably prior to better screening, better postoperative care, and better ICDs, the most common cause of death in the adult population was arrhythmias who had congenital heart disease. But after that, the composite endpoint of myocardial infarction and ischemic heart disease-related heart failure remains and has established itself as the major cause of death for all patients with congenital heart disease. This is just an interesting slide looking at when patients are diagnosed with coronary artery disease, because it helps to frame the discussion as to what we should expect as a field as our patients age. As you can see, all comers, and the green line is really the line of importance here. The mean age of diagnosis of coronary disease in the United States has been about 57 to 59 years of age. There are differences in sex. That is a discussion that's beyond the purposes of this discussion at the moment, but the question will remain, are we as a field going to be seeing patients present younger, older, and are they going to present with the same predilection toward coronary artery disease? And I would say for the moment that time still has yet to resolve this issue. But what we do know so far is that our patients are living longer. They remain at risk for cardiac mortality. And in this similar paper, in the same paper by the Diller group et al., there does appear to be an inflection point around 60 years of age as well, which is kind of interesting because it very much mimics the general population incidence of coronary artery disease and resulting mortality from this disease. So as you see here, all comers, there does appear to be, I'm not sure if you can see my pointer, but if you can, there's a bit of an inflection point after 60 years of age. This is mimicked in simple complexity and moderate complexity, but of course, great complexity, congenital heart disease, the risk of death is quite more substantial and a bit more constant than it is with less complexity congenital heart disease, which you would expect. So the risk, if we look at why patients develop coronary artery disease, probably the most productive way of looking at them is to assume that they have, by and large, the same risk factors as patients with the general population, because these are, by and large, either modifiable or at least able to be monitored risk factors. And they're all the usual suspects: hypertension, diabetes, smoking, et cetera. There are some theoretical reasons why adult congenital patients might develop early coronary disease, things like abnormal coronary courses and coronary manipulation during various operations that have been well described, Ross, transposition, et cetera. Various genetic syndromes that can either have a primary effect on coronary disease or can be associated with ventricular hypertrophy, aortopathy, and et cetera. Thus far, we have not seen a large population of patients who are dropping dead of coronary disease or who are requiring significant interventions for this yet. And this is likely due to the massive heterogeneity in our patient population. There's a differential risk profile in cyanotic and acyanotic children. There's probably insufficient data, and we do need more time to accrue patient years, particularly in those very complex congenital heart disease surgeries, some of which have only been pioneered in the last 30 to 40 years. We should talk a little bit about why patients with cyanosis don't develop coronary disease. And I'm sure this will be a bit of a review for some of us, but the chronic erythrocytosis does lead to shear stress in the vessel walls, which increases nitric oxide and increases nitric oxide production, which will then decrease platelet aggregation, will inhibit monocyte adherence and infiltration, which will then inhibit smooth muscle cell proliferation within the media. And this chronic hypoxemia that these patients have as well will also decrease the oxidized LDL, which is a bad actor in terms of foam cell, et cetera, creation. And the breakdown of erythrocytes will lead to hyperbilirubinemia, which will further decrease LDL oxidation. And that is indicated clinically by the fact that patients with Gilbert's disease do not actually develop coronary disease. So there are also additional models of this in human disease. So what does all this mean? What it means is that there's pretty much a negligible incidence of coronary disease in cyanotic patients, but as will be the case for the rest of our patients, it is probably still best to screen them according to the current guidelines, barring any increasing accrual of data otherwise. So when we're talking about the traditional risk factors of coronary disease in our adult patients, they do seem to have a similar comorbidity profile to the general population. And that is to say, they're just as unhealthy as the rest of us. And in a study out of Belgium, there were almost 2,000 patients, and they said that only 20% of those patients were without any cardiovascular risk factors. And that was somewhat disturbing, considering the fact that the median age of these patients was only 26. So by 26, only 20% of patients, or rather looking at the other way, 80% of patients had at least one risk factor for cardiovascular disease. And the majority of these patients actually had even more than one risk factor. So this is a young-ish population that has risk factors that are likely going to manifest themselves in the future. So we're going to talk a little bit about the traditional risk factors and how they may or may not have a differential incidence or risk in adult congenital heart patients. Hypertension is a big one. About 30 to 50% of our adult patients will have some form of arterial hypertension. And that's similar to the general population. And this has been described in a couple of larger series. There are certain conditions that are more associated with systemic hypertensions. The big one of which, of course, is coarctation of the aorta, which even after repair does confer a major risk of developing and maintaining systemic hypertension throughout the course of the patient's life. But interestingly enough, despite the association with hypertension, the diagnosis of coarctation alone is not an independent risk factor for the development of coronary disease. That may play out later, but for the moment it has not. The data on obesity are mixed as to whether or not our adult patients have a greater incidence of obesity. And that's likely due to, as will be the case in most of this discussion, the fact that this patient population is so heterogeneous. You can imagine some of the most severe disease patients will have some element of either sarcopenia or malnutrition, and that could be driving this. We just don't know. But what we do know is that Dr. Pasquale put out a few papers on this, which was that up to a third of patients after the Ross procedure or the arterial switch were obese. And these obese children, this had downstream consequences. And these are just children. So just to give you an idea, they had higher systolic blood pressures, higher triglycerides, and lower HDL. And these were patients in the course of 10 to 15 years of follow-up after their Ross and their arterial switch operations. So this has a potential for increased coronary burden in certain subsets of patients as they age. And remember, arterial switch is not exactly an old operation that has been performed for quite some time. And many of these patients are just now reaching middle age. There's mixed data on exercise as well. And this is probably due to the fact that there's a differential perception among patients and among practitioners as to the safety with which exercise can be performed in its various forms. And this is something that warrants much further discussion, but sort of beyond the focus of this talk at the moment. Fortunately, it doesn't seem like these patients smoke a lot, but the incidence is not zero. So that will certainly be something that will be important for counseling these patients as they age. The data on hyperlipidemia are mixed, likely due to the fact that there is, in many cases, an underlying genetic and lifestyle predispositions toward the development of this. Interestingly enough, the combined endpoint of metabolic syndrome or obesity, dyslipidemia, insulin resistance, and hypertension does seem to be more prevalent in acyanotic adult congenital heart disease patients than in the general population. So again, the importance of screening these patients cannot be highlighted enough. So the question then becomes, is this a real problem? So for the next few minutes, I'll sort of highlight, it kind of depends on how you ask this question and who you ask it to. Because not to be too pedantic here, but what the definition of adult congenital heart disease is actually an important definition for us all to agree upon if we're going to ask the basic question as to whether or not the adult congenital heart disease population has a differential risk compared to the quote unquote general population. The literature is filled with patients who are primary adults who are diagnosed with an ASD or a bicuspid aortic valve presenting in middle age, and they are classified as patients who have adult congenital heart disease. Many of us would probably agree with such a distinction, but these are the predominant patients who are represented in the extant literature on the subject of congenital heart disease patients who present with coronary disease. Are these patients the same as adults who have had childhood or neonatal congenital heart disease surgery? Are they different than Eisenmenger adults, some of whom are still very much out there and do sometimes present with coronary disease? Cyanotic patients as well. These are very different physiologic substrates that are all put into the same bucket of adult congenital heart disease, but they likely have differential risk factors for the development of coronary disease. So there are two major types of studies that have been done, and there are these global incidence studies where they look at all patients with adult congenital heart disease and they survey as to whether or not they develop coronary disease or if they don't. They're free from the sort of surgical capture bias, but the question as to how best to capture this immense and heterogeneous patient population is still a very challenging one to work out in terms of study design. The surgical subset studies are interesting. They talk about patients who present for surgery for other reasons. They have a surgical bias, of course, and they're center specific. And we'll talk about all those over the next few minutes. So the global incidence studies have been very well done. The first of which was in 2009. It looked at all ACHD patients who were having a cath for reasons that were other than for suspected coronary disease, to free them of the bias of having patients who likely had coronary disease. And so they found a 9.2% of severe coronary disease among 250 patients. And what they found, perhaps expectedly, was that no cyanotic patients and no young patients had severe coronary disease, and this mean age was 51 years. So that was an interesting contribution. The next one was a bit larger of a study, but a much lower incidence of coronary disease, only 1% of these patients. However, the interesting thing about this study was that 14% of those patients were less than 40 years of age. So sort of adding to the debate here. And this was further highlighted by a Dutch study that was done several years later, where they had a similarly large patient population who they followed for the combined endpoint of a coronary-related event, which is either a hospitalization of acute coronary syndrome or death by myocardial infarction. And what they found was that the relative risk for a coronary disease event in patients in their 20s was 12 for women and 4.6 for men, which is astonishing. But really what that means is that you're comparing it to a general population. The risk of a major coronary disease event for a patient in their 20s is probably so insignificant that any event for these patients would be considered a major thing. This differential in risk, in relative risk, remains significant, but much lower until the patients were in their 5th decade of life, and then it resolved to the same level as the general population. So just very interesting discrepancies in the data as to when these patients develop and how severe the disease is. The surgical subsets look at patients who present for adult congenital heart disease and in the process of their workup get a coronary workup. One of these had about 73 patients. 22% had coronary disease, but only 3% had severe that required a concomitant CABG. And this was highlighted as well by an Italian study that had many more patients, but pretty much the same incidence of severe coronary disease requiring a CABG. But again, only 7 of these patients had a prior sternotomy. So my perspective on this is a little bit different, because most of our adult patients are reduced sternotomies because we get a lot of these referrals. And 40 out of these 50s were just, quote unquote, just ASDs. So the vast majority of these patients are ASDs and bicuspid valves. So when you remove those, interestingly enough, the incidence of severe CAD in their adult population went down to only 0.8%. So widely discrepant incidence of coronary disease, the burden of that disease, and the surgical implications of that disease based on how you stratify and based on how you define what is an adult congenital heart disease. So I would argue that the adult congenital heart disease population has at least the same risk profile as the general population for developing coronary disease. But interestingly enough, the interventions for these patients do seem to be on the rise. There was a 3-fold increase in PCI among patients with adult congenital heart disease from 1998 to 2005. The burden of this is also increasing. Myocardial infarction is rapidly rising and establishing itself as a cause of death in acyanotic patients with congenital heart disease. And the presence of coronary disease does confer a 5-time relative risk of death in adult congenital heart disease patients who are over the age of 60, which again goes back to the inflection point that we saw at the age of diagnosis in the late 50s and early 60s of coronary disease. There may be certain cyanotic ACHD subtypes or acyanotic subtypes that might be at higher risk, although this really has yet to be determined with larger population studies. But what we can say almost for sure is that as this population continues to age and grow, which fortunately it does, and fortunately it will, their burden of being as unhealthy as the rest of us and being subject to the same disease as the rest of us will also continue to grow. So finally, for just about a minute or so, is this a surgical problem? I'm a surgeon, many of us are surgeons. Is this actually important for us? And I would say not really. The CABG outcomes in these ACHD patients do appear to be similar than the non-ACHD patients. The freedom from re-intervention is good. The mortality is more determined by the additional concomitant procedures that are performed as part of the ACHD surgery, as well as the underlying patient morbidity or comorbidities with which they present. But this is all in the setting of having the vast majority of surgical series being quote unquote just primary ASDs and bicuspid valves that are presenting as a primary sternotomy. So I would actually argue that the additional risk of CABG with concomitant ACHD procedures, certainly the more complicated ones, has yet to be determined. The risk or the use of mammary usage, unfortunately, is lower in the larger series, but this is likely confounded by a wide range of reported surgical errors and incomplete operative records, et cetera. But fortunately, there don't appear to be any differences in outcomes between adult and congenital heart surgeons performing ACHD CABG, although many more studies probably need to be done on that. So finally, just to summarize things, and I realize I'm going over, so I apologize, but as our patients do continue to age and as the patient numbers continue to increase, these issues will certainly persist, they will not go away. Do we need specific coronary disease guidelines for ACHD patients? I would argue at this point we do not, but that should certainly be an ongoing subject of discussion. We should continue to do the thing that benefits the most people in the best possible way. And currently, there's no reason to suggest that the guidelines are insufficient for our ACHD patients. Should there be different screening for acyanotic versus cyanotic? I would argue there should not be, because although we do not have a whole lot of data to suggest that cyanotic patients develop coronary disease, that missing such a thing would be potentially catastrophic, and the screening process is not terrible. Should we further specify based on disease substrate? I would argue that we have insufficient data to do that, but it certainly should be something at the forefront of our mind as we continue to stratify these patients in the future for their operative and also for their coronary disease risk. And overall, at the risk of repeating myself too many times, the best guidance does remain the current screening guidelines. And the only thing that I would argue is that potentially these patients should undergo selective angiography of the IMA, particularly in redo settings, just because there can be various calamities that can befall a patient in prior operations, and the immediate availability of records is not always there. So it's best to know prior to particularly redo sternotomy whether or not you're going to be able to use that mammary because of the survival advantage that it does confer. So with that, I would like to thank you all again for your attention and for the opportunity to present this talk with such a great audience. And I'd be happy to answer any questions if anyone has any. Thank you very much.
Thank you, Constantine, for a splendid talk. I think for your excellent talk and the two previous talks, one could say that the new aspirational mantra of being slim and athletic applies for the Fontan patient from the moment of Fontan completion to the patient with aortopathy to the whole congenital heart population, because the best treatment for any condition is prevention. So I think we just need to sort of emphasize this and go back to patients and families and couples and say that congenital heart patients have a good outlook to life, a great outlook to life. There are, infrastructures to support them through the way, but they need to assume certain responsibility and make the right life choices. Absolutely wonderful talk and really appreciate it. We may have some time for discussion at the end. Thank you very much.